All right. We've got a ton of studies to catch up on, and hopefully the background music that I got playing right now doesn't take up too much of the sound from here. But let us begin. First up, dry needling plus manual therapy and exercise for subacromial pain syndrome, a sham-controlled study. This one basically said after a year, did adding dry needling or other interventions really improve the outcomes for people with subacromial pain syndrome? And while the totality of the improvement was not any different between the groups, whether you received conventional care or whether you received conventional care plus dry needling for subacromial pain syndrome, there was improvements in secondary outcomes. And what they noted was that patients had a better perception and comfort, and I'm using that in quotations because dry needling isn't really the most comfortable intervention, but they were more able to do the physical therapy or conventional therapy in the moment because of the window that for those people the dry needling was able for them to do. So again, the totality of the improvement that the patient had was no better, but in the moment while they were having to get through whatever hurdle it was to improve the subacromial pain syndrome from a conventional or exercise-based intervention standpoint, making the dry needling part of their care made the exercise more palatable to them. So it made it more adherent to stick to what actually got them better. So again, does dry needling cause or is that the healing factor for subacromial pain syndrome? No. Like I don't want anybody to think like any manual therapy is the cure for pretty much any of their conditions. However, its short-term benefit is and can be applied to patients to give them that window to actually want to do or be able to do the proven long-term improvement care that is exercise therapy, physical therapy, chiropractic sports therapy, whatever you want to call it. So that's what this study really backs up. Totality of care, no different between groups. In the moment, the patients that were in the dry needling group found it more palatable to do the physical therapy. So next up, increased adiposity, so excess fatty tissue and impaired sleep were associated with the severity of greater trochanteric pain syndrome. Some people are also now calling that gluteal tendinopathy, so a tendon issue with your glute muscles. Makes the greater trochanteric pain syndrome, the gluteal tendinopathy, worse, which just reiterates and backs up our approach at the clinic, taking a whole person approach. So if you come into my clinic and you're like, hey, I hurt here, and I've hurt here for months to years, and we both realize that there are other factors to your health that need improvement, we're going to attack them because whether it is direct or via indirect mechanisms, improving your totality of health will improve focal conditions, or they will factor into the severity of improvement and the speed of improvement for what is oftentimes the chief complaint that you have. Without rambling, basically what I'm trying to say is if you have a lot of things that are clearly unhealthy in your life and you are suffering from a musculoskeletal issue, we can do a lot of care in the moment only musculoskeletally. So short-term care, including manual therapy with the long-term goal of having some sort of exercise-based therapy to lock in those results. However, if we want to do our due diligence and stack the deck in your favor in all regards, we must include the totality of your health, not just the focal issue that you're complaining of, because these things in some cases are additive, in other cases are multiplicative, where if you have excess fat, if you have very terrible sleep, like you're sleeping 4 to 5 hours a night, those have such a significant impact on your health. I would be lucky to resolve your actual complaint in the moment. And it would just be that. It would be in the moment. Because I could pretty much guarantee you this thing is creeping back and it will be cyclical. It will be a chronic, recurrent issue because part of the, I'm going to use air quotes a lot, I can tell, the root cause of your issues is more than just that focal issue that you're complaining of. So with that tendon issue in your glute, yeah, that's what's kind of rearing its ugly head, but that didn't just happen overnight. That happened with years, months to years of holding on to that excess fatty tissue, months to years of getting poor sleep. So you actually can't go through and repair yourself. We can't successfully rehab you, take care of you, etc., if we don't address the whole person. Now, next up, hypercholesterolemia, so excess cholesterol in your body that they measure via blood draw, and lumbar degenerative back pain. What can you guess the study found? Give you a moment. Let's jump right to the conclusion. In this particular study, subjects with hypercholesterolemia, so again, let's just call it poor blood cholesterol numbers that you got from your doctor, were 34% more likely to have back pain after controlling for other confounding variables in a U.S. population. A lot of the times, cholesterol is associated typically with lifestyle diseases. So it could be that whole canary in the coal mine where, hey, you may maybe feel good or now you're not doing too bad yet. However, your annual physical with blood work came back, or if you're going with us and you want to test it more frequently, like every 3 to 4 months, and just get a better pattern of it. Hey, your cholesterol numbers are ticking in a way that we don't like. We should probably address if it's a lifestyle factor, the lifestyle factors that lead to those poor numbers. If it's a familial genetic issue that we can't really, like, we can influence it, but we may not be able to cure it and get it great. Maybe we consider co-managing with your doctor with some pharmacologic therapy to actually get you some relatively healthy numbers. That way, we reduce your chances of developing some pretty bad degenerative back pain in your near future. So again, conversations where we may be able to preempt or nip in the bud a problem that, again, if you let this brew for years, it's like, hey, I just found out between last year and this year, I went from good cholesterol numbers to poor cholesterol numbers. Great. We have a window where it's not really sitting in your body for too long. Let's address it now. Versus like, oh yeah, I've had bad cholesterol numbers for 10, 15 years. It's like, that's 10 to 15 years of daily cumulative buildup that it's going to be, when it's going to hit you, it's going to hit you hard, and it's going to be harder to pull you out of it because now we have that many years of your poor or less than optimal. What am I thinking? What is the word that I want to use to describe this? That is 10 to 15 years of less than optimal biochemistry in your body that we now have to account for and try to manage out and away from. So this is why, again, if you don't get blood work on a semi-consistent basis, start. The more data points you get for your providers, the better. You don't need to go overboard with, $600, $1,000 worth of blood tests. You can get these, a core panel, a core set of relative value pretty economically efficiently, like whether it's through me, through your doctor, through an open lab. Like there's a lot of options, and you don't need to get a million things. You just need like a core, I don't know, core 4. Get get a CBC that doesn't tell you too much, but it just makes sure that nothing is happening in the moment. Like there's no, excess white blood cells that we have to be concerned about, worsening infections, and it can help show us your hemoglobin. So do we have to worry about anemia? Maybe you should consider a metabolic panel, lipid panel. Those would be the big ones. And then Okay, let me phrase it this way. Those are ones that you should get on a semi-consistent basis. Then there's ones that are on a less frequent basis that you only need to check once in a blue moon because they're either genetic or the numbers don't change quick enough that warrants you getting them so often. Um, so like, for example, let's take somebody in my family. We reach a certain age, and in our family history, we have some issues with prostate. So part of their checkup was getting a prostate specific antigen test to see if there's any potential issue with the prostate that's going on. And that's one where if it comes back abnormal, you test again just to make sure it wasn't a false positive, and then you go in to check with an MRI. Like it's a step process of screen. Yep, both screens came back positive. All right, let's actually see what's going on. That's not one that you need every 3 months to assess kind of how you're trending. That's just, do you have yes or no? The metabolic panel and the lipid panel really helps us assess how your body's forming and playing with fats, with cholesterol, and those are things that you want to trend and track and make sure that we are consistently healthy, because that's where if you derail, like we just saw with that study, you have higher incidences of bad juju stuff, whether it's MSK related, low back pain, degenerative back pain. But then you also have the other scary stuffs like, what have we heard with poor blood work, heart attacks, strokes, etc. So just let's do our due diligence and not go 20 years without seeing a doc. Like, oh, I know I'm healthy. Oh, you might feel healthy, but you should really check it. Like, I can't tell you how many times that has happened, whether it's through my patient base or my colleagues' patient bases, where people were feeling great, but then the lab work showed, hey, whoops, or you get the random x-ray for, hey, I hurt my elbow. Well, within the x-ray, they see like something going on in the bone itself. Um, like a lot of these happenstance findings are almost, there's enough of them happening that if we just incorporate more consistent screening from a population standpoint, we could probably nip in the bud a lot of the Facebook stories that go to terrible endings. So if we just do a better job as a society, not waiting 10, 20 years to get a blood pressure, for goodness sakes. Like I used to do DOT testing. When these guys and girls would see me for DOT testing, it would be like, hey, when did you last see your doc? I don't. When did you last have a blood pressure taken? I had my last physical. Well, are you on a 1 year or 2 years? Like I'm on a 2 years. Like, so your last blood pressure was taken 2 years ago. Yeah, and I passed. Yeah, thankfully at 135/80. It's like, uh, that was 2 years ago, and that is that normal for you? It's like, oh yeah, that was a good day. It's like, oh goodness, no, 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 that's bad. You're letting that blood pressure go for that long, that poor. No, like, I don't want to turn this into a 2 hour thing. Like, we do not want sustained high blood pressure for reasons that should be obvious. If not, go to the American Heart Association, go to all of the American Academy of Cardiovascular Surgeons, of cardiologists, like look up what, sustained high blood pressure, hypertension 1, hypertension 2, what it does to your body and what you're putting yourself at risk for. We just need more consistent screenings. Like, you don't like the doctors, you hate going to the doctors. Fine. I am not saying you need to be under care, paying, ER visits, urgent care. You don't need to be doing any of that sort of stuff. But with access to open labs, with access to inexpensive blood pressure monitors, especially home units, just somewhat consistently taking a look at your health periodically to give yourself and your potential future provider, even if you don't get one, God forbid you have an incident where you go to the ER, you have a history that they can draw from to give you a better chance for a good clinical outcome. Holy smokes, apparently I had that cooking for a while because that was way too long of a rant. Let's keep going. Getting back on course, tempo mandibular disorders and neck disability in individuals with cervical disc herniation, I'm going to nip this right in the bud. Basically, all of the patients, almost all of the patients that they found that had cervical disc herniations had some level of TMJ involvement, whether it was primary pain complaints or secondary, just generic jaw issues. I've said it so many times before. If you have a jaw issue, look at the neck. If you have an in at bare minimum, like if you have a shoulder issue, no, I'm not looking at your pinky toe per se. Like that's too far apart. However, these are right next to each other. It makes sense that there is a high level of overlap. Just like with low back pain. If you have low back pain, does that necessarily guarantee you have a hip issue? Guarantee, no, but the odds of them playing off of each other and being a factor in either's resolution to one another is significant. So just be open to checking at bare minimum adjacent areas when somebody comes in with a complaint. Next study, collagen pathologies and lumbar disc herniation and its recurrence. If you have ligamentous diagnosed conditions, whether it's generic ligament laxity or something like Ehlers-Danlos syndrome, odds are you're going to have a higher incidence rate of lumbar disc herniations. Now, is that in and of itself bad? Because with or without symptoms, the odds of you finding a disc herniation in your body because of your makeup is higher. That's all that means. Next study, we're just going to do these faster. Effects of eccentric muscle force, so controlling a muscle while it's getting longer, on shoulder internal impingement on a cadaver model when they put it in a late cocking motion of throwing. This one is a conceptual piece only because cadaver models are only so valid when it comes to actual body motion. It gives us an idea because we see how the tissues passively, even though they talk about eccentric and all these things, cadavers are only so mimetic to actual human movement. So conceptually, this is cool. Basically showing that people that throw baseball, javelin, everybody that does this motion, so volleyball, this in this late cocking motion, they measured how much pressure that ball socket joint of the actual shoulder while it sits in to the socket, so scapula, ball socket, boom, how much pressure this was exerting on this surface. And when they set these cadavers up, they found that when they toned down the amount of eccentric ability of the muscles, the greater the actual impact or force that the ball was putting on the socket, giving us a potential mechanism for people who have shoulder pain when they're doing this, and a potential reason for why exercise-based therapies that work a lot of this, subscap, lat, infraspinatus, like all these muscles around the rotator cuff and shoulder, if we're able to improve their capabilities, capacities, and control in our throwers, why they typically have some sort of resolution of their symptoms. So again, this is prospective. It is cool. It's a cool concept. And it may be something that we can use as an explanatory reason for getting a patient to go through care. Like, well, why are we doing this if my shoulder hurts? It's like, well, if we give you better control, we might be able to reduce the actual force that your shoulder is putting pressure on the part where you have pain. Is it an absolute guarantee? No, there's a lot of things to consider when it comes to shoulders. Tendinopathies, capsular issues, fractures, fibrous disorders like frozen shoulder, which we'll be talking about in a little bit, actual pressure the shoulder is exerting, colic issues, like pain is complex. The shoulder is highly mobile. There's a lot to consider. So this, at least, if a person needs an explanation, is a potential explanation that we can give in an appropriate context for the right patient at the right time. Now, again, just like I'm doing with you. All of these are prospective, not guaranteed. I'm not actually putting a patient in an MRI machine and watching the entire articulation of their shoulder at any given moment in time. And even if I were able to do that, always see the I know we can't. So that's why I spent so much time saying prospective. It's like even in the conclusion, the internal impingement area and the contact pressure that the glenohumeral joint exerted decreased with increased forces of those muscles on the shoulder joint. So, neat concept. Some food for thought for later and something to keep in our mind if we see other studies that start to overlap and maybe say something similar. Next study. Patients with Achilles tendinopathy show reduced intratendinous sliding during dynamic exercise. Okay, I don't want to spend too much time on this one. So your Achilles tendon, the big thick tendon that goes from the bottom part of your calf and inserts on your heel bone, isn't just one long piece of symmetrical tendon tissue. It's not just like a uniform cable. I don't have anything around me that'd be like a good example. Think of it this way. There are multiple parts of the muscle that are interweaving at different rotational angles. That's a difficult concept. So let's see if I can do this. So you have one part of the tendon going from calf down to heel. Part of the muscle tendon, so as it's forming from muscle down into tendon, stays somewhat straight. It has a little turn to it, so a little tiny corkscrew as it goes down into the heel. There's another part that really corkscrews, so as it comes from that muscle, goes down to the tendon, it like significantly turns down and corkscrews so that the fiber, like if you were looking at it like you were to cut it, you see a spiral effect because it's turning as it's inserting into the actual heel. These two parts where there's a little bit of corkscrew and a lot of bit of corkscrew are right next to each other. So again, this would be the calf area. This would be my elbows would be the actual heel point. So let's see if I can do it this way. I'll give this one an extra turn so that you can kind of see that this one turns more. This one's more straight. When you're doing dynamic movements, sprinting, jumping, cutting, these two parts don't just move in unison. They will slide past each other. Okay, they will work interdependently for a unified task. What that means is when you develop a tendinopathy, it matters where you have that tendinopathy symptomatology in a patient, and it also matters that you expose the heel to more than just single plane movement because of how these forces interact. It also means that part of the pathology of the tendon, you can have intratendinous sliding reduced. So rather than being able to slide with one another to do their tasks towards a common goal, they kind of get stuck and they tack together. And again, it's a difficult concept to do on just this without an actual app to show you things, and I don't have the time or the ability to set that up yet. But part of the goal of care is to get different parts of those tendons to start reforming so that they can slide past one another again without that tack, because that might be a big factor in why the patient presents with Achilles tendinopathy. In this study, they kind of call it as a marker of tendon health. So if you have reduced ability for those tendons to slide past one another in the Achilles tendon, the tendon isn't as good of health as we'd want it. So what they said for this one is, we suggest that foot positioning may be a simple way to enhance sliding, can be used as a factor for clinical rehab. Given the poor rehab outcomes for Achilles tendinopathy in general, implementing external foot positioning during rehab protocols may offer a low cost and easy to implement method to improve rehab success rates. So this is why, do you need surgical level knowledge of anatomy to be a good clinician? No. But you do need enough to understand certain pathological concepts and why, even though general physical preparation programming may be sufficient to a point, you need just enough knowledge to understand the concepts of rehab for the pathology in front of you to make a big enough impact or the right impact for the right patient at the right time. So while most people will benefit from just a generic general physical preparation program, there are certain conditions, patients, and categories that would really only resolve in a healthy manner, healthy time frame, healthy cost, health, etc., with practitioners that know these little details. So again, is it required for everything? No. But some of these nagging conditions that have poor outcomes, part of that is because people aren't getting an appropriate level of care. Now I've said something that I gotta take like 30 seconds and talk about. Most conditions that are suffered in the US from an MSK perspective can be taken care of by just doing the bare bones basics that is mentioned in all of our health journals. Get enough movement, enough exercise, eat well, etc. That would handle a huge chunk of what is seen in a majority of offices. There are specific subgroups of diagnoses that can't necessarily be avoided by that, and only relying on GPP principles will only get you so far because of the nature of the pathology. So there are things that happen like acute disc herniation that causes significant pain and radiculopathy that may warrant a lot of oversight from a clinician, because if that disc herniation starts to impair the foot to an extent, or not the foot, impair the nerve root in such an extent that it causes significant foot drop and inability, et cetera, et cetera, et cetera, that's bad. That may warrant surgical intervention. If you have somebody that it's generic whiplash associated disorder, some of those, not too bad. Can rehab without too many issues. Some have a lot of symptomatology overlap with concussion, and you got to make sure that you understand what the patient is capable of at any given point and standpoint. So having this knowledge of these conditions aid in actually being able to resolve specific patient cases. So again, GPP, great for most people. When there's a specific issue that actually requires specific guideline care, that's when you need to upgrade, and that's why you need to know some of these studies, because Achilles tendinopathy can be a bugger to resolve because there's a unique insertion mechanism between the tendons that if we don't take into consideration at some point during your care, there may be a reduced ability for you to actually get better if you have Achilles tendinopathy. I've spoken way too long so far. Let's just keep going. And I swear, if this music that I hear in the background actually is overriding what I'm saying, I don't know what I'm going to do, because I spent so long actually trying to talk through this. Okay, predictors of response to physical exercise for low back pain. Reviewing an actual trial of workers, they found that if you had a higher initial starting point of back pain and you're able to implement the exercises, you had a greater response or a greater improvement to your low back pain. If you were on anxiety medication or you had poorly controlled levels of anxiety, you responded worse. So good news for low back pain management. If you're able to do the exercises and you're not very anxious, you have a good chance of resolving it. If you're anxious, but you then actually take care of some of that anxiety through all appropriate means, whether it is pharmacological or non-pharmacological, managing that anxiety puts you in the same category and you're able to resolve that back pain. So pain is multifactorial. You have a lot of different components to it. Next study. Evaluating diagnostic consistency. Can other observers agree upon rotator cuff tears in ultrasound videos? Yes. This is just backing up. You don't have to always jump to MRI. Now, in a lot of cases, MRI is the standard of care and the gold standard for a lot of conditions. However, if we just suspect a rotator cuff, there's enough people or there's enough evidence to show that diagnostic ultrasound, more accessible and cheaper, has great accuracy to diagnose rotator cuff tears. So if we suspect at least that pathology, we can start you off with a diagnostic ultrasound. If we suspect other things like, hey, I just dislocated my shoulder for the first time last night, well, we could follow the process of get an x-ray first to check for fractures, but odds are good, even if we're clear, if you have symptoms, we should probably just jump to MRI because there could be cartilage within the joint. You know, what level of tearing did you have of the labrum? Because the odds of you having an intact labrum after a dislocation, not great. And, you know, what other shoulder injury did we have because your shoulder was allowed to fully dislocate and come back in, especially if it's your first time and you don't have any actual laxity in the joint beyond what is normal for the shoulder joint. That can have significant forces going through the shoulder. We should probably just jump to an MRI to assess the state of the shoulder. So if it's just a rotator cuff, ultrasound. If it's something bigger like first time dislocation, we'll probably just go straight to an MRI because that can look for all the things. That can look for the fractures, the cartilage, the muscle, etc. Next study. Familial risk of carpal tunnel syndrome among relatives, and does it interact with obesity and high blood sugar? Yes. If you have a family history of carpal tunnel syndrome, that already puts you at a higher risk of developing carpal tunnel syndrome. If you were overweight and had a little bit of higher than normal blood sugar, you had worse odds. If you had even worse, so if you were obese and you had type 2 diabetes, levels of hyperglycemia, you had an even better chance of developing carpal tunnel syndrome. Suffice it to say, it wasn't exactly dose dependent, but the odds were worse. So it's like the more overweight, the worse the blood sugar combined with family history, the more likely you were of developing CTS. Next study. I promise, guys, we're almost done. I've only got a few studies left. Neck muscle function after neck-specific exercise in individuals with chronic whiplash-associated disorder. Long story short, these people had neck problems or problems stemming from their neck. They finally exercised the neck. The neck got better. That's all I have to say about that. Don't ignore the neck as an actual structure to rehab, to exercise, to get better. I mean, I had a tension headache earlier today. I was able to take the edge off, not cure it, not fix it, but I was able to take the edge off because I started doing range of motion drills, isometric drills. I started getting my muscles working in my neck. So if your neck pretty much in even GPP, even general physical preparation, you should include some sort of neck exercises. However, if you have a condition that has a factor stemming from your neck, you should at some point, if it's a factor, you should have something that is programmed for the neck as well. Do you need an hour of just doing neck exercise? No, but you shouldn't have 0 minutes done for the neck either. The national burden of gout in people aged 15 to 39 from the years 1990 to 2021. Yeah. What was the trends in the US? Bad. The trends were getting worse with gout. Shocker. You're more sedentary and we eat like campground raccoons on a daily basis. We're probably going to develop gout. Let's get ahead of this. Let's move. Let's eat better. Let's sleep better. Let's be better. Gout sucks. We don't want it. Let's reverse that trend. Next, instrument-assisted soft tissue mobilization as an approach for children, ages 10 to 11, with chronic neck pain, a randomized study. Again, this one was comparing it to, I think, massage. Let me double check this one. And classical massage in children ages 10 to 11. Like any other study, this only showed short-term improvements. Short-term as in the patient came in with chronic neck pain. They were assessed. They did the questionnaires. The researchers wanted them to do. They received either intervention within that same testing intervention. So once the practitioner was done, they asked the patient how they did. They took a look at range of motion and algometry. So they took this pressure sensor and put it on the painful area, and it measures essentially a PSI, and at what threshold do you have pain. Lower PSI is associated with worse pain because you had to put less pressure in before the patient felt pain. So yes, once you actually did these treatments to the patient, within the moment they felt better. But again, they basically say there's no idea as far as how this affects patients long term. I would posit that, like every other study, if you only do manual therapy, you're only going to see the result in the short term. Like we saw with the dry needling study for the shoulder impingement, the subacromial pain syndrome. If you look at the totality of the person's improvement over a long period of time, the implementation of the actual manual therapy won't really play a role in the totality of the improvement on the long face of their care. However, in the moment, like for example, right now, I had a tension headache. Am I going to go out and do everything that I would do in my normal weightlifting program? I would do as much as I could, but I know that that's only so much with this tension headache, which means if I received something that would give me short-term improvement in my condition, whether that is, and again, I'm not talking about me personally, I'm talking about anybody on this other side of the screen, whether that is some sort of manual therapy, chiropractic care, acupuncture, physical therapy, pharmacologic over-the-counter, pharmacologic prescription, whatever that is, I would feel better in the moment, and then I could go hit the gym like I more normally would. So again, did the implementation of that manual therapy today, if you did it, if you were able to do it today because you had neck pain in the moment, a year later, would I be better off than if I didn't do it today? No, because that's not what gets me better over long term. Exercise, movement, and things that I do make me better over the long term. But I would not, I didn't. I didn't do my exercises today because I felt like crap. So if we have somebody with a chronic condition that feels like crap more than once a week, frankly, even that's too much. I shouldn't say too much. You shouldn't feel 100% all the time. That's too much of an ask. However, if we have somebody that has this condition multiple times a week or even daily, the odds of them going through what you know you want them to do to get them better over that entire year period, the odds go down. So if I'm able to, whether it's in the first stage, second stage, or even it has to be over the entirety of the course of their care, because that's what they, we both want for them is the actual exercise. If the manual therapy is a strong piece or a strong encouragement for them to do that, I'm going to do it. Okay. But I don't hold any illusion that the manual therapy is the cure. The exercise lifestyle changes are the cure. The manual therapy is just something that helps knock down the barriers along the way. So for me in the moment, today's barrier, tension headache, if I was able to knock that out, I could have done what I wanted. For somebody that has these chronic recurrent issues, that manual therapy or the lifestyle, nutritional, pharmacological interventions, whatever it may be, if that gets them to a threshold that lets them hit the GPP, general physical prep, the exercise, if it lets them hit that stuff harder, that's all I'm going to say about it. Okay, we're almost done. Dry needling and instrument-assisted soft tissue mobilization alongside conventional physical therapy in patients with cervicogenic headache both worked. Like other studies we've covered that do this exact same question, both worked. It's just a matter of some worked better than others. This one favored instrument-assisted slightly more, but both worked very, very well. I think I've done a half a dozen videos easily on this almost exact same study. This is just adding more fuel to the fire and more clinical confidence in my understanding of when, how, where to use either instrument-assisted work or dry needling, and hopefully for you as well. Next up, comparison of rotator cuff muscle thickness and acromial-humeral distance. So acromial-humeral distance, part of the, so your collarbone's here, it meets up with an acromion here to form a joint, and you have this space right here between the actual glenohumeral joint, the ball part of your shoulder, and where your shoulder or clavicle meets the scapula right here. So they compared the muscle thickness and the distance in overhead adolescent athletes with and without rounded shoulders. Why is this important? Some people claim that static posture will crimp down these spaces, leading to impingement, leading to pain. This study put that to wash. Like, no, it doesn't matter passively if a person, you know, perfect posture, rounded posture, these kids functioned just fine. And just similarly, like, let's go to the conclusion. There is no significant difference between the two groups in the thickness of the shoulder musculature, which would indicate a difference in movement dynamics that may favor one or the other, and the acromiohumeral distance. Further research needs to be conducted to rule on the effects of age, sports history, and duration of the shoulder roundness on results. And they do a couple of caveats like, hey, even though we use muscle thickness as an indicator, it may not always correlate with muscular performance of athletes during sports. Going back to my point, it doesn't matter passive posture. So if I maintain this awkward passive posture and then I cock and try and throw, that would have an effect on the throw. However, if I have the posture of a wrestler, but when I go to cock and go to throw, I dynamically come into a better form, throw, and then when I relax, I'm in this rounded posture again. It didn't matter that my passive static posture was a little more rounded, because what matters is the moment of the movement. We see this with a ton of other conditions too, like somebody like, oh, I have flat feet, therefore I can't. It's like, well, hold up. You have passive flat feet. Give me a calf raise or go up onto your toes. Let's see if you develop an arch when you go up on your toes. If you do, great. You have a functional medial arch, which means when your muscles contract, your arch develops, your foot, your medial foot gets the structure that it likes during your movements. If you go up on your toes and that flat foot stays, now it's structural. And now that's a different condition. So what really matters isn't the appearance of something. What matters is the function of something. Now, yes, there will be people on this YouTube app, wherever this, on Instagram, social media, that will constantly harp on form follows function. That is true to a point, because we make the false assumption that passive form equals active function. Okay? 100% of the time. Okay? Passive form is not the same as active function. I want us to conceptualize active form with active function. So what do I mean? Well, let's just go back to my foot example, my medial arch example, and then I'll tie it back to this throwing example. Your passive structure, your passive form, your relaxed form, standing in a person's office, you have no medial arch, your flat foot. We shouldn't jump to the conclusion that your active function is going to be significantly damper. Like, oh, we need to get you in a really high orthotic, and we really need to make sure that we put you in all of these shoes, these specialized shoes, yada, 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 yada. Somebody just looked at your feet and said, as they're relaxed, you just don't have an arch. Nobody took the time to look at, hey, when I ask your foot to go up onto your toes, Does it have the function and ability to create that arch? Yes, it does. Great. It has functional, appropriate motion. So then it becomes the question of, is it something that we rehab? Is it something like we're able to ask questions from here? We just don't jump to the conclusion. Do these patients need orthotics? Maybe some. Do they need rehab? A lot of the others. Is it an issue that even if they feel it around the foot, is it an issue with the medial arch? Don't know. Like this this hypothetical, I don't know. Maybe it is, maybe it isn't. These athletes, rounded shoulders, okay, depending on the age, could be just a growth period. Could be a cultural period of they're sitting in school for 6 hours with no recess, maybe a half hour phy ed, and they're developing pain not because their passive structure stinks, but because they don't have the physical capacity built up anymore because they're not as active as they should have been. So they just happen to have shoulder pain, and you just happen to see somebody with a rounded posture. Now, again, maybe that's just their growth point and their body's developed a movement pattern that actually accounts for that. So even if, again, you just see them like this, what if during their throw, they open up into a moment of better posture and are able to do a beautiful throw, but then they just return to a relaxed, rounded posture? Whoop-de-doo. Okay, especially in adolescence, bigger whoop-de-doo. There's so much room for growth. There's so much natural asymmetries happening because of growing. Like we honestly, I think we try way too hard to have too big an effect on kids way too soon. We really need to kind of treat this like driving a boat, like just give a little course correction, give it time, because that little course correction may have profound effects if you just wait. And maybe that's one of those things where, oh, something's on the horizon. All right, let's wait. Let's see. We don't need to course correct yet. Oh, yeah, it is in our path. All right, just do a gentle course correction now and just give it time. We will clear the barrier without too much of an issue. We don't need to be on jet skis, zipping all over the place, going, we need to fix everything all the time, all at once. No, no, just no. All right, last article. Ooh, this one was a marathon, wasn't it, folks? Causal effect of education on low back pain. What does that mean? It means the people that weren't educated on, well, first, in general, they took a look at demographics of people that have generally lower educational levels, lower terminal degrees, lower levels of grad school, lower levels of et cetera, et cetera, et cetera. But then they also looked at people who were getting education on their actual condition. And what they found was if you were more likely to be educated on the condition you were suffering from, the better your odds of having a positive result, a positive resolution of that condition. And this one was talking about intervertebral disc degeneration and sciatica. So if we go to, I'll read the conclusion first, but then I'll backtrack to the results. The findings suggest that higher educational attainment may have protective effect against common spine-related disorders. Enhancing education-related resources could support early prevention and reduce the population burden associated with these conditions. So in the results, let's see, how do I break this down to make more sense of it? Actually, it pretty much reiterates the same thing. It just talks about different categories and different data banks that they were pulling them from. I wanted to end on this one because a big chunk of my job and a big chunk of what I aim to have my clinic do is educate. Like a big reason that you ever sign on with me and actually get under my care, yeah, we'll do absolutely everything an elite level clinic will do, like top of the line, hands-on care, top of the line, management of most of the conditions that are within my scope to manage, referral networks between providers when appropriate, full lifestyle. Like we'll give you the full Monty. I'm not looking to have 1,000 patients at $10. Like I'd rather flip that. I'd rather have 10 patients at $1,000 because the amount of time that I put in you to actually get you to your goal, nobody's going to match me. And that, well, in my mind and my goal is that I put so much effort into it that it would be bloody hard to match the amount of effort that I'm putting into you to get you to your goals. That's how I want to operate. And amongst all the things that I can do for you, the biggest one is education on your condition, on why we're doing things, when we're doing things, how we're doing things. Because at the end of the day, I should be training you to be able to handle whatever it is that led you into my office. And really, all right, let's end it with this saying. Frankly, the only thing that separates a very, very quality physical therapist, chiropractor, uh, frankly, between each other, nothing. Nothing should separate those two. But what separates the doctorate level terminal degrees from a really solid personal trainer is simply scope. That's it. My additional training led me to be able to manage different diagnoses, to be able to say I can treat and manage painful conditions, that I can screen for and manage a lot of the debilitating lifestyle issues, that we could rehab post-surgical cases, fractures, that we essentially, I have additional training in screening, additional license and scope and ability to order imaging when appropriate, and to legally manage the more complicated medical cases. But the actual process, the actual things that get a patient better, is just the same as a solid physical therapist, is the same as a solid personal trainer, lifestyle coach. Like our goal, all of us, from S&C coaching, personal training, chiro, PT, lifestyle, all of it should be education. That should be the thing. And it just manifests as different physical results depending on the provider. So S&C coach, that education will lead to their clientele being more physically capable at their sport. Somebody learning under a personal trainer will meet more of their personal training goals, whether that's bodybuilding, physique competitions, general physical preparedness, weight loss. Somebody under my care, again, it's just what's the goal? I want out of pain. Great. My education will get you there. The additional flavorings are just what we dictate is appropriate at the right time to get you there in addition to the education. So like, hey, do I need to get cracked all the darn time? No. Why not? Because you don't need it. But I like it. Great. Does it feel good? Yeah, it does. Do you hurt enough that I should do it in the moment? Well, I hurt X, Y, and Z. You know that exercise is going to be the best thing, right? Yeah. All right. Can I just crack your back so that it feels better to do the exercise? Sweet. Education was the thing. We just told him it's not going to be the thing that fixes him. He knows that exercise is going to be the thing that gives long-term results. I was just there to educate him, and I have the license to just say that some of these things can help reduce pain and get you the results we want. But I've ranted way too long. I think this one's an hour long. I hope everything I said makes sense, and thanks for sticking with me this long. If you even watch the YouTube video, or if this comes across as an Instagram short, sweet. But until next time.